Good evening. It is my pleasure today to welcome you all, my professors and colleagues from Egypt and Arab world. Today, I'm sure that Dr.mohamed Abdel Gawad, who is the consultant in Alexandria, Egypt, and the founder of and administrator of NephroTube, it is well known for all colleagues in nephrology and in the medicine. He is a board member of Egyptian Society of Nephrology and Transplantation, junior representative, and I hope to be accepted by a friend to be a representative as well for African young colleagues. He is a board member of the renal registry. So Dr. Abdel has a lot of activities in education, and this is his evolution of education from MBBSH 2004. So he is now 16 years experience in medicine. And lastly, in 2018, he was achieving a good degree, specialized in nephrology, which is Mansoura Medical Doctorate degree in nephrology. And I am very proud of Dr. Mohammed to be one of our members. He is still growing in research. He has humble research activities. This is one of his research about spontaneous Achilles tendon rupture in patient was undergoing long-term hemodialysis. A very nice case showing a problem in dialysis patients, and I think it's a problem for many patients who are treated with statin. And one of the very nice articles that I like it because it is one of the assignment of MD nephrology that was translated into review article, and I hope to be a reality in Egypt. I know we have Professor Faissal Shaheen, and the kidney PEAR donation is a reality in the Gulf area. But up to this moment, we are waiting legalization to have kidney PEAR donation instead of doing the desensitization approach for patients with incompatibility. Lastly, Dr. Abdel Gawad had this abstract that was accepted to be presented in the ISN that was not held because of Corona, but the abstract was published in the Kidney International Report early this year. And this is his abstract assessment of awareness and the knowledge of bodybuilder. And this is a very nice and important to be careful about the gym and gym nephropathy, a lot of issues related to by using drugs and diet. Dr. Abdel Gawad enriched the CME. He has 68 lectures for the Egyptian Society of Nephrology, 13 videos. And as you see, some of them, this is the last webinar about urine analysis, viewed by more than 3,000 doctors, and as well as how to examine AV fistula. And it was in English because it was among our courses for the African countries. 18,000 watched the video of fistula examination. Today we have the chairperson, Dr. Tarek El-Tantawy. He's a senior consultant of nephrology and the vice president of Gharbiya Renal Association. And he is Secretary General for Egyptian Renal Data System with Professor May Hasaballah. Dr. Tarek El-Tantawy has many presentations within the virtual academy, 45 lectures. I'm sure that he doesn't know this number and the videos. And among these 15 videos that were recorded to the channel, Dr. Tarek El-Tantawy has this presentation about uric acid and the kidney. This is why I'm expecting hot discussion with Dr. Abdel Gawad at the end of the presentation. So this is the uric acid and the CKD. This is the topic of the session today. I am sure that Dr. Abdel Gawad is one of the best who can deliver clear messages about the evidence. And when we say uric acid and the CKD, because uric acid may be associated with acute kidney injury like tumor lysis syndrome, I think it's not our goal today. We are going to, I think Dr. Abdel Gawad will hit uric acid and the CKD aspects. I'm going to stop here and to allow Dr. Abdel Gawad to share his slides. And until he shared his slides, I'm leaving the mic to Dr. Tarek El-Tantawy just to welcome and to start the session. Dr. Tarek.
Many thanks for your professional introduction for all, me and Dr. Gawad. And I am waiting a prestigious presentation about uric acid and the kidney, because we faced in our clinical practice a lot of cases got benefit from that proper approach and wise approach. You are more than welcome, Dr. Gawad, and we are actually waiting for your presentation today.
Thank you very much. Thank you very much, Dr. Tarek. Before they start, I'd like to welcome all my professors and colleagues, because I see now Professor Riyad Saeed. So it is, I think he will enrich this session by his valuable discussion. Dr. Riyad, you are welcome to join us always.
اهلا مساء الخير.
اهلا بك.
and looking forward ان شاء الله للمحاضره بتاعت الدكتور عبد الجواد. دكتور طارق سعيد اني اشوفك ان شاء الله, and we have a good talk باذن الله. Thank you.
Thank you, Dr. Riyad, and we have Professor Faissal, Prof Dawlat Belal, Professor Saeed Khamis. So I'm expecting a hot discussion at the end. Please, Dr. Abdel-Gawad, start your presentation. Unmute yourself, Dr. Mohammed.
Hussein, for this introduction. Uric acid and chronic kidney disease is one of the most debatable issues we always meet in our practice. I will try to show the evidence and appraise it, trying to reach at least a slight consensus regarding how to manage these cases. At the start, as we all know, that uric acid is formed secondary to the degradation of proteins and nucleic acids and the fructose metabolism. Uric acid has an antioxidant effect, but it may cause kidney disease by different theoretical mechanisms. Whenever the uric acid in the soluble or in the crystal shape, it may affect the kidney and cause kidney disease theoretically by increasing NAD pH oxidase and other factors, which will lead at the end to glomerular and systemic hypertension, glomerular sclerosis, and tubular interstitial fibrosis. My talk outline, I will cover hyperuricemia in CKD, and also only one slide about hypourecemia and chronic kidney disease. In hyperuricemia, I will cover hyperuricemia in CKD who are not on dialysis to treat or not, hyperuricemia in CKD on dialysis to treat or not, gout management and how to use urate-lowering therapies in chronic kidney disease, and finally, some drugs and medical conditions that may affect uric acid level and may coexist with chronic kidney disease. Starting by the first point, hyperuricemia in chronic kidney disease who are not on hemodialysis to treat or not to treat. Chronic symptomatic hyperuricemia or gout patients who developed CKD, we have to treat this patient with lifestyle and the use of urate-lowering therapy for the sake of the management of symptoms of gout. If the patient has chronic kidney disease and later he developed gout, this patient too we have to treat hyperuricemia using lifestyle and urate-lowering therapy to treat the symptomatology of gout. And these patients, usually CKD patients with chronic symptomatic hyperuricemia or gout, you will find serum urate concentrations often higher than expected for the degree of renal impairment. The uric acid will be higher than the degree of renal impairment. The debatable point or issue, the development of asymptomatic hyperuricemia in CKD patients who are not on hemodialysis. In these patients, yes, we will use lifestyle for the sake of hyperuricemia and for the sake of chronic kidney disease as general. And the debate about the use of urate-lowering therapy in these patients, to use or not to use urate-lowering therapies in asymptomatic hyperuricemia in CKD patients who are not on hemodialysis. Before going through this debate, why chronic kidney disease may cause asymptomatic or hyperuricemia, as we all know that proximal convoluted tubule physiologically has important role in the reabsorption and secretion of uric acid. about 8 to 12% of the filtered uric acid will be excreted by proximal completed tubule. So in chronic kidney disease, there will be modest hyperuricemia secondary to the reduced efficiency of renal excretion of urate. So to use or not to use urate lowering therapy in these patients, I will cover the available evidence and I will appraise it. I will mention some special situations and finally a proposed approach. Starting about the available published evidence, guidelines and trials. First of all, all the studies I will show, there is always conflicting and contradictory results between all studies and guidelines. This may be secondary to the difference in the design of the different studies because of the heterogeneity of patients, heterogeneity of the baseline GFR of the patients included in the studies, heterogeneity of the risk factors, and many other factors may affect the study design, including unmeasured and unadjusted confounding factors. So I will show now many trials and studies and guidelines. Some of them suggest or recommend the use of urate lowering therapy in asymptomatic hyperuricemic CKD patients, and some are not. Starting by the available published guidelines. In 2012, the KDIGO guidelines mentioned that there is insufficient evidence to support or refuse the use of agents to lower serum uric acid. They didn't recommend or suggest the use or not to use because of the weak available evidence in asymptomatic hyperuricemia and even in symptomatic hyperuricemia to delay progression of CKD. Even the evidence to use urate lowering therapy to manage symptomatic gout in CKD patients will not, or there is a debatable evidence about its effect to delay progression of CKD, but we use urate lowering therapy in symptomatic patients for the symptoms and treatment of gout. But the evidence to delay progression also is very weak. Later this year, 2020 SCR guidelines, they are against the management of asymptomatic hyperuricemia even in CKD patients. And also the French guidelines 2020, also they are against it. They didn't recommend initiation or indication of urate lowering drugs in asymptomatic hyperuricemia. The only guideline that supported the use of urate lowering therapy in CKD asymptomatic hyperuricemic patients is the Japanese guidelines. They mentioned that if the patient is asymptomatic but has a serum uric acid of equal to or more than 8 and the presence of CKD, you can try pharmacological treatment. So the guidelines are debatable, although the most famous guidelines are against the use of urate lowering therapy. What about the available trials and studies regarding this issue? We have a very large pool of studies. Some are with the use of urate lowering therapy in asymptomatic CKD patients, and some are not. We have contradictory studies at the level of experimental evidence. At the level of observational studies, we have a lot with the use of urate lowering therapy and some are not. And even at the level of randomized controlled trials and meta-analysis. I will not go in depth through this table or through the appraisal of these studies, but I will mention the most two recent randomized controlled trials. They are not in this table, but I will add them. The PEAR study and the CKD Fix study, which were published recently in New England Journal of Medicine. Both of them are against the use of urate lowering therapy in asymptomatic hyperuricemic CKD patients. I will analyze these two studies because they are the most recent. I will start by the PEAR study. Both of them were published in the same edition of New England Journal of Medicine in last June. The PEAR study, they tested the use of allopurinol in CKD patients with type 1 diabetes. They enrolled 530 patients with type 1 diabetes and mild to moderate diabetic kidney disease with a GFR from 40 to about 100. They gave the patient allopurinol versus placebo and followed the patients for about 3 years. At the end of the 3 years, the serum uric acid sure was lower in the arm which used allopurinol, but no change in serum uric acid in patients who received the placebo. Regarding GFR, measured GFR, they used measured GFR after 3 years. There was no difference between the two arms, the allopurinol versus placebo. And they concluded that there is no evidence of clinically meaningful benefits of serum urate reduction with allopurinol in kidney outcomes in type 1 CKD patients with early to moderate kidney disease. But the question now, can this study be generalized? Can PEAR study result be generalized to all type 1 diabetes CKD patients who have asymptomatic hyperuricemia? Let's see. The GFR of the patients included in the study was from 40 to 100. So what about patients with lower GFR? What about moderate to severe CKD? They were not included in the study. The second important point, the age of the patients included in the study. You will find that the range of the age was from 40 to about 60. So mild to old age. What about younger ages with asymptomatic hyperuricemia? We have no evidence. Even most of the studies tested the urate lowering therapies in asymptomatic hyperuricemia enrolled patients with moderate to old age, with middle to old age. Finally, the serum urate of the patients who are involved in the study, will find an interesting point that some patients involved in the trial had normal serum uric acid. And this was strange. This PEAR trial and the CKD fixed trial that I will mention later, both of them involved patients with normal serum urate in the study. Can PEAR study be generalized to other CKD patients, non-diabetic patients? The answer is also no. If you see in the supplementary appendix of the study, the exclusion criteria, as we said, the study was on diabetics, so this wasn't tested in non-diabetics. They excluded patients with hepatic disease, which is very common to see in our CKD patients. They excluded patients who are anemic, which is very common in our CKD patients, and they excluded patients with any congestive or pulmonary insufficiency, which is also very common in our patients. So this study cannot be generalized to all our patients. Regarding the second most recent trial, which is CKD fixed trial, CKD fixed study. In this trial, they enrolled 363 patients with CKD stage 3 to 4, and these patients had albuminuria or rapidly progressive CKD. They defined rapidly progressive CKD by decrease in eGFR more than or equal 3 ml per minute in the preceding year. They gave an arm placebo and the other arm allopurinol, followed the patients for 2 years, and finally the outcome that there was no difference between the allopurinol arm use and the placebo use regarding GFR and regarding adverse events. And again, they concluded that urate lowering treatment with allopurinol didn't decrease or decline, didn't halt decline in GFR in patients with high risk of progression of CKD. But again, the question, can CKD fixed study result be generalized to all CKD patients who are albuminuric or with high risk of progression? Let's see. First, again, the age of the patients included in the study was of old age patients from 50 to about 70, 74 years old. So what about younger patients? Also, the patients involved in the study are of stage 3 or 4 CKD. What about early stages of CKD who may also have progression, but at early stage? We all know that halting progression may be easier at earlier stages of CKD because of limited fibrosis than late stages of CKD 3 or 4. And also there is contradictory evidence to CKD fixed trial. We have more than many evidences regarding the use of allopurinol with rapidly progressive CKD, and showed that allopurinol was appropriate and had a benefit. Although all of these trials, patient number was small, and there are several issues were raised about these trials. regarding the quality and the biases, but we have contradictory evidence. Even CKD fix have some issues that I mentioned, and I will mention more now. Back to the CKD fix trial, we said that they included all the age patients. They included only patients with CKD stage 3 or 4. Finally, the serum urate, they also involved patients with normal serum urate in each study. CKD fix trial had two more important issues. The first, that their enrollment to the patients was stopped because of slow recruitment. They intended to include 620 patients in the study, but they couldn't recruit the 620, they recruited only 369 patients. The recruitment was slow, so they started the study with the 369 patients. So what is the problem? The problem is that there is insufficient power in this study as a result of incomplete enrollment, and that means that there is a difficulty in recruiting patients who met the criteria of the study. So possibly this indicating limitation in the generalizability of the results. I can't generalize to all patients because they didn't find the patients within their selective criteria. The last issue that is related to the CKD fix trial, that about 30% of the patients who are taking allopurinol stopped allopurinol during the study, and about 25% stopped the placebo intake through the placebo arm. At the end of the study, yes, those who stopped the allopurinol had lower serum uric acid, but at least they stopped the allopurinol. So finally, we have an evidence, recent evidence, that urate lowering therapy is not indicated to be used in asymptomatic hyperuricemic patients, but I think it has a lot of issues and debates. That's what will make me mention some special situation. The first is the young age. As was mentioned in this editorial in New England Journal of Medicine about the PEAR trial and CKD fix trial, they mentioned that they didn't include young age patients. And the conclusion in clinical research, more high quality randomized controlled trials are needed in this age group. Even not the PEAR or CKD fix trial. If you revise the all randomized controlled trial and meta-analysis testing the use of urate lowering therapy in asymptomatic hyperuricemic patients, you will find all of them enrolled or recruited patients who are old age. The second special situation of the young age, the non-proteinuric mild to moderate renal impairment. The PEAR trial is one of the most famous trials that at the end they concluded that febuxostat failed to decrease CKD progression. But after sub-analysis of the PEAR trial, they found that allopurinol was effective to delay progression in patients with CKD who have no proteinuria and serum creatinine level below the median level. Also, another meta-analysis of 832 CKD patients showed a good benefit of urate lowering therapies in patients with mild to moderate renal impairment. So this is another debatable issue. And finally, solitary kidney. We don't have a direct evidence about the use of urate lowering therapy in hyperuricemic patients who have solitary kidney. But we have indirect evidence about the relation between serum uric acid and GFR deterioration in patients with solitary kidney. This evidence came from this study. They studied the effect or the association between the pre-donation serum uric acid and the residual renal function at 6 months and 1 year after nephrectomy, after renal donation for transplantation. And they found that the higher the serum uric acid before donation, the lower eGFR and the residual function at 1 year, but that was significant only in female patients. So we don't have a direct evidence for solitary kidney, but also we don't have an evidence or a proof to not use urate lowering therapies in asymptomatic hyperuricemic patients with solitary kidney. I would like to show you now a proposed approach that was published in Kidney and Blood Pressure Research Journal. In this approach, they suggested that if the patient has asymptomatic hyperuricemia, you have to measure EGFR, uric acid proteinuria for 6 months. If the patient is stable, so don't use urate lowering therapy. If there is CKD progression, start using urate lowering therapy for 6 months and measure GFR. If the use of urate lowering therapy caused a slow rate of progression, continue the therapy. If no effect on CKD progression, stop it. That was a proposed approach that I would like to show it to you. I am not supporting it, but just for discussion, and I want to add to it. First of all, I will put a question mark between CKD progression, because again we have a debate. Some studies show that progression is not affected by urate lowering therapy, and the other showed a benefit. And I will add these special situations. What about non-proteinuric mild to moderate CKD according to Wither trial? What about young age patients that we don't have any evidence about the use of urate lowering therapies in them? And what about solitary kidney that is not involved in most of our trials? So I think that we need individualization. To summarize what I said about the use or the treatment of hyperuricemia in CKD patients not on dialysis, the asymptomatic part, there is a debatable evidence to treat or not to treat. Scale arm is more toward not to treat. The strongest or the more evidence is toward not to treat. But what about CKD progression, especially after controlling other factors and especially in early CKD stages? What about non-proteinuric mild to moderate CKD patients? What about young age patients and patients with solitary kidney? Second point I will discuss now is the hyperuricemia in CKD patients who are on hemodialysis, to treat or not to treat. First of all, we have to know that uric acid is dialysable. It differs according to you are using a high flux or low flux, but in average, it is dialysable by about 60%. And most of the uric acid, serum uric acid, is removed during dialysis in the first hour, and the removal decreases by the development of the dialysis. So to treat or not to treat, you have a CKD patient who is on hemodialysis. If the patient had chronic symptomatic hyperuricemia and gout symptoms, yes, you will need to treat the patient with lifestyle and urate lowering therapy. But what about asymptomatic hyperuricemia in CKD patients who are on hemodialysis? Urate lowering therapy to use or not use? That is the question. These are 14 randomized controlled trials in hemodialysis patients with asymptomatic hyperuricemia. They tested the association between serum uric acid levels and the mortality in end-stage renal disease patients. 9 of the 14 studies found an inverse association between uric acid and all-cause mortality. So the higher the uric acid, the more the protective, the less the mortality. And this is what is called in our patients reverse epidemiology. We know that reverse epidemiology, that abnormal factor in the patient will give a benefit to the patient against the general population. And our CKD patients are a pool of reverse epidemiology. We need our patients to be hyperparathyroidism. We need our patient to be slightly anemic, slightly obese patient mortality is less on hemodialysis. So our patients of CKD are a good example for reverse epidemiology in medicine. So 9 of 14 studies found an inverse association between uric acid and mortality, although some studies, 5 studies, either found no association or direct association. But the strongest evidence goes toward that the higher the uric acid, the more the protective. Why the higher the uric acid may be protective? If you look to this graph, the solid black line is of a patient with high serum uric acid and on dialysis. The gray line is for patient with low serum uric acid and on hemodialysis. Patients with high serum uric acid, let's take this point. The serum uric acid is 8.5. This was the measured uric acid before the dialysis. After the dialysis session, you will find the uric acid of the patient dropped to 3.4. Then the uric acid increases gradually till the next session. So what I said that between the end of this session and the start of this session, look for the uric acid level. It increases gradually, which will make this patient serum concentration of uric acid attain nearly toward the normal level. The average is about 5.7 of this patient, which could be sufficient to exert the antioxidant effect of uric acid. But patients with low uric acid before dialysis, say this patient had 4.5 level of uric acid. After dialysis, it will decrease. We said that uric acid is dialyzable. It will decrease to 1.8 and increase gradually to 4.5 before the next session. So all over the week, or all over the duration between the two hemodialysis sessions, the patient attain low serum uric acid. Also, we all know that in maintained hemodialysis, serum uric acid is a good nutritional marker, and this may be the benefit. But even when they adjusted various confounders, including the malnutrition inflammation syndrome, they found serum uric acid, which is high, is also effective and protective in hemodialysis patients. So to conclude my second point, hyperuricemia in CKD on hemodialysis, asymptomatic hyperuricemia is considered protective. Okay, what about gout management? How to use urate lowering therapies in CKD patients? What are the dose modifications and the precautions? Let's talk about management of gout flare, gout attack, a patient with gout attack. Referring to the 2020 American College of Rheumatology guidelines for management of gout, they strongly recommended the use of oral colchicine in general population, whatever on CKD or not. And I will modify according to chronic kidney disease later. But what they said to use oral colchicine, non-steroidals or glucocorticoids, either oral or injections. If there is a problem for using anti-inflammatories as non-steroidals, they suggested they conditionally recommended interleukin-1 inhibitor if the patient cannot tolerate well non-steroidals. And finally, the patients can use topical ice. Okay, what we are afraid in our CKD patients, can we use these medications as it was mentioned by American College of Rheumatology guidelines? Let's start by colchicine. Why we are afraid from using colchicine in CKD patients? This is because of colchicine toxicity. Colchicine toxicity risk factors are many. One of them is decreased kidney function. So with the more decreased kidney function, the more possibility of colchicine toxicity, which is very dangerous. Also, many risk factors may cause colchicine toxicity. All of them can coexist in our CKD patients. Colchicine toxicity presents mainly by neuromuscular symptoms, blood dyscrasias, gastrointestinal manifestations, and even up to death. So this is very important that patients that will use colchicine must be monitored closely. So if you decided to use colchicine, what is the recommended dose? For normal kidney function, colchicine is used in the dose of 1.2 milligram at the first sign of gout flare. Once the attack appeared, use 1.2 milligram. Then after 1 hour, use another 0.6 milligram. Then repeat 0.6 milligram every 12 hours till the gout flare disappears. What about CKD patients? If the patient was on colchicine for prophylaxis, I will mention prophylaxis later, so it is not recommended for the management of the flare because the patient is already on colchicine prophylaxis. For creatinine clearance more than 30 ml per minute, there is no dose adjustment required. But again, colchicine toxicity is a dangerous point. We have to modify the dose if the creatinine clearance is less than 30. We have to decrease the dose. How to use it? Use 1.2 milligram at the first sign of flare. Then after 1 hour, use 0.6 milligram. And don't repeat colchicine for at least 14 days again. So use it once every 14 days in this dose regimen. What if the patient, there is another expert opinion to not use 0.3 milligram. They recommend, or 1.2 milligram. Some experts recommend to use 0.3 milligram at the first sign of flare. So you can repeat it at less frequencies every 3 to 7 days. But the most common and famous approach is the first one. What about CKD patients who are in hemodialysis, who developed gout, and you need to give colchicine? It is very dangerous. But if you decided to give colchicine, you have to give only 0.6 milligram as single dose. Okay, it is not removed by dialysis, and don't repeat it before 14 days. Okay, again, you can use a smaller dose with less frequencies, but the most famous and most approved dose is the first one in the table. Again, as I said, colchicine hemodializability is very low or even non-dialyzable. It is about less than 10%. Regarding non-steroidal, I will not go in depth through it. We all know the dangerous effect of non-steroidal and its effect on kidney disease and progression, but may be used in hemodialysis patients. Steroids may be the other drug that we can use it instead of colchicine or non-steroidal if you don't want to use them. And finally, if interleukin-1 inhibitors is available in your country, you can use them at the last line, and they have also dose modifications. After gout flare disappeared, you have to give the patient a prophylaxis after the management of the gout flare. How to give the prophylaxis? Regarding colchicine and normal kidney function, it is used by the dose of 0.6 milligram every 12 hours, or even it can be sufficient to use once. In CKD patients, creatinine clearance more than 30, no dose adjustment required. Less than 30, start by 0.3 milligram per day. And again, close monitoring of the patients because of side effects. On hemodialysis, it is very dangerous to maintain the patient or prophylaxis with colchicine, who is on hemodialysis because of mild neurotoxicity, and the FDA approved only 0.3 milligram twice a week if you use it. You can use non-steroidal, but you can use only in normal kidney function, which are not our patients, and in CKD patients on hemodialysis, but you can't use for CKD on CKD patients with stage 1 to 5. And finally, prednisolone or glucocorticoids may be considered as alternative in patients who can't use colchicine or non-steroidal. For how long I will use this prophylaxis? It is suggested, as it is strongly recommended by 2020 SCR guidelines, is to continue prophylaxis for 3 to 6 months. And another important point that is new in 2020 SCR guidelines, that they recommend, conditionally recommended to use or to start urate lowering therapies during the gout flare. As we all know, the old evidence or data to start the urate lowering therapies after the disappearance of the gout flare. But in these guidelines, they conditionally recommended to use or to start urate lowering therapy during the gout flare. So to conclude the management of flare of gout in CKD patients, take care of colchicine toxicity, use lowest effective dose, avoid non-steroidals as possible. Steroids and interleukin-1 inhibitors may be alternative in patients who can't adapt or accommodate colchicine or non-steroidals. What about long-term management of gout in CKD patients? What are the available drugs to be used? As we all know, the allopurinol and febuxostat are vansioxidase inhibitors. They inhibit the conversion of hypoxanthine to xanthine, so they will decrease uric acid level. And we all know the uricosuric drugs. They act on the different channels and proteins in the proximal convoluted tubule, prevent uric acid reabsorption and increase uric acid excretion. And finally, the rasparicase and the biglyoticase that convert uric acid to the soluble allantoin. In general, the use of rasparicase and its family of drugs are preserved for patients with high burden uric acid and high burden cell turnover as in tumor lysis syndrome. And as was mentioned by SCR guidelines, it is not recommended as first line for management of hyperuricemia, chronic hyperuricemia. Regarding uricosuric drugs, they are contraindicated, as I will mention later, with lower GFR, and usually with the decrease in kidney function and glomerular filtration rate, the effect become weaker. So the cornerstone mainly in the management of hyperuricemia in our patients are allopurinol and febuxostat. So which is better to start with, allopurinol or febuxostat? This question will make me to show this evidence, which is the CARES trial, that compared the febuxostat versus allopurinol in patients with gout regarding the cardiovascular safety. And this was a randomized controlled trial stratified by renal function. There was CKD patients involved in this trial with stage 1 up to stage 3. What did they found? They found that febuxostat increases cardiovascular mortality and all-cause mortality than allopurinol. Although there are some debatable issues related to this trial too, especially that some patients who died on febuxostat, they found that they stopped the febuxostat earlier and they died when they are not on febuxostat. But this evidence that from this trial that febuxostat increased cardiovascular and all-cause mortality make the guidelines and the FDA to suggest avoidance of febuxostat, especially in patients with cardiac disease history. The FDA approved that febuxostat increased the risk of heart-related death and increased the risk in general of death. And that what makes the ACR guidelines to mention that they conditionally recommend to avoid febuxostat in patients with history of cardiovascular disease or new cardiovascular event. And also the French guidelines mention that at the start of the use of urate therapy, if the patient has severe cardiovascular disease, it's better to avoid febuxostat. And that what makes the ACR to strongly recommend the allopurinol to be the first drug of choice in management of hyperuricemia, even in patients with CKD stages more than or equal to 3. But what we are afraid from the use of allopurinol in CKD patients, we are afraid of reaction. Allopurinol has severe adverse events, all are related to reaction. Different syndromes, all are related to reaction. The allopurinol hypersensitivity syndrome, the DRESS syndrome, drug reaction with eosinophilia and systemic symptoms, and finally the Stevens-Johnson syndrome and toxic epidermal necrolysis. All of these can be developed, especially in patients with lower eGFR. So what if you decided to administer allopurinol to your patient? What is the dose modification? Starting by its normal dose in general population, allopurinol can be started at a level of 50 to 100 milligram daily and titrate the dose according to response, and you can reach up to 800 milligram per day. What about CKD patients? If the patient creatinine clearance is more than 30, you can start with lower than 100. And if creatinine clearance is less than 30, you can start by 500 milligram per day. This table shows more details according to GFR. With the lower the GFR, the lower allopurinol starting dose. What about patients on hemodialysis? How can I start allopurinol if you will start it? In intermittent hemodialysis, because allopurinol is dialysable, you have to administer it post-dialysis. Start with 100 milligram on alternate days post-dialysis. Okay, I mentioned now what is the dose to start allopurinol in CKD 3 and 5 and CKD patients on hemodialysis. But what is the maximum dose in our CKD patients? As was mentioned by American College of Rheumatology guidelines, patients with CKD may still require dose titration above 300 milligram per day to achieve the serum uric acid target. But it's very dangerous in these patients, and they conditioned this statement by appropriate patient education and monitoring for patient toxicity. So if the patient is not compliant, the patient is not following up well in the clinic, it's better to avoid these high doses in patients with CKD. What about febuxostat renal dose modification? In general population, you can start by 40 milligram per day and titrate slowly. You can reach up to 80 milligram and even up to 120 milligram once daily. In our patients, if creatinine clearance is more than 30, no dose adjustment required. If creatine clearance is less than 30, the maximum dose is 40 milligram once daily. In dialysis patients, there is no evidence or provided dose adjustments, but in a small trial, they used a dose of, in Japanese, about 10 to 20 milligram per day in hemodialysis patients. Finally, uricosuric drugs, all of them are contraindicated in hemodialysis patients, and most of them are contraindicated in lower GFR. And as I said, whenever GFR going down, their effect and side effects become more. Last point and statement, which is new also in the American College of Rheumatology, Guidelines for Management of Gout. They strongly recommend to start prophylaxis from the start against gout when you initiate urate lowering therapies in your patients. And finally, this is a list of ongoing trials of new drugs for the management of hyperuricemia. Most of them are within phase 2 or phase 1 trial, and they are not published or approved now. So to conclude, long-term management of gout in our patients. Febuxostat has bad cardiac effect. Allopurinol is preferred as first line, but take care of reaction as a side effect. Use lowest effective dose, whatever the drug you use. Titrate dose according to response with close monitoring. And finally, uricosuric drugs are contraindicated at low eGFR. The last point or statement regarding the hyperuricemia in CKD patients is drugs and the medical conditions affecting uric acid level. Our patients are using drugs that may affect uric acid level and may develop some medical conditions that may coexist with CKD that may affect uric acid level. Starting by drugs, common drugs that may cause hyperuricemia. A long list of drugs. Some of them are very common to be used in CKD patients. For example, immunosuppressants. If the patient is CKD secondary to glomerulonephritis, you may use cyclosporin or tacrolimus. Diuretics and aspirin in low dose. And aspirin in low dose is protective, cardioprotective, and many of our patients are cardiac and are on aspirin low dose. And as aspirin low dose is very important, the American College of Physicians, American College of Rheumatology guidelines put a statement about this point that they are strongly recommend against stopping low dose aspirin even if the patient is hyperuricemic because of its benefit. So don't stop low dose aspirin if the patient is hyperuricemic, because you will gain more benefit from this cardioprotective effect than hyperuricemia. Again, as we mentioned, drugs that cause high level uric acid, also our patients may take some drugs that decrease serum uric acid level. The most famous is losartan by name. It decreases serum uric acid level, and also the new era or propaganda, the SGLT2 inhibitors decrease uric acid level, and others. Regarding antihypertensive medications, as I mentioned, losartan decrease serum uric acid level, and another evidence showed that calcium channel blockers also may decrease risk of gout. So calcium channel blockers and losartan are associated with lower risk of incident gout, but diuretics, beta blockers, ACE inhibitors, non-losartan angiotensin II receptor blockers are associated with increased gout. That's what makes the ACR guidelines to conditionally recommend to switch if the patient is hyperuricemic and on hydrochlorothiazide, to switch hydrochlorothiazide to alternate antihypertensive when feasible. And they conditionally recommend to choose losartan as a first line of therapy in this patient because of its hypourecemic effect. Besides the drugs that the patient used that may affect uric acid level, our patients may develop other conditions that may coexist and affect uric acid levels. Many clinical disorders that may cause decreased uric acid clearance and affect uric acid level in our patients, but I will highlight the most important two related to us, which are hyperparathyroidism and hypothyroidism. Hyperparathyroidism, which is very common in our patients, decrease in uric acid clearance, and hypothyroidism also, which is evident in our patients, may affect uric acid level. And also, there are many etiologies that may increase purine biotensis and urate production. I will highlight some of them. Vitamin B12 deficiency may coexist in our patients, and you will find this patient has AZA-resistant, anemia resistant to erythropoietin-stimulating agents. And sure, we have to exclude myeloproliferative, lymphoproliferative disorders and the malignancies in our patients, especially the serum uric acid is very high, out of range to the CKD stage, especially in uric acid more than 11, 12, or 13. So to conclude this point, we have to consider other drugs and the medical conditions that may coexist and affect uric acid level, and we may exchange drugs that affect uric acid level if their clinical benefit is not important. If their clinical benefit is important, we have to maintain them as, for example, lower dose of aspirin. Finally, hypourecemia in chronic kidney disease patients. Is it good or is it bad? Hyperuricemia in CKD patients, lower uric acid is associated with increased hazardous ratio of all-cause mortality. The lower uric acid, the more the mortality. So hyperuricemia is a bad effect. Hyperuricemia is dangerous. Uric acid has a U-shaped curve, as most of the factors in our patients. Hypertension in CKD patients have U-shaped effect. Parathyroid gland has a U-shaped effect. Body weight, nutrition, phosphorus, all factors affecting CKD patients have U-shaped effect. So the lower the uric acid, the higher all-cause mortality. So hyperuricemia and CKD increased all-cause mortality. So I think this table is enough to be my home messages. To conclude, management of asymptomatic hyperuricemia in CKD patients who are not on hemodialysis. Evidence is debatable regarding to treat or not to treat. The scale, the arm of the scale is more toward not to treat. But what about these conditions which where there is no strong evidence in them regarding CKD progression, especially after controlling or factors and early CKD, non-proteinuric mild to moderate CKD patients, young patients, and solitary kidneys. Regarding hyperuricemia in CKD patients who are on hemodialysis, asymptomatic hyperuricemia is considered protective. Regarding the management of gout flare, take care of colchicine toxicity with lower GFR, use lowest effective dose, avoid non-steroidals, steroids, interleukin-1 inhibitors may be alternatives. According to long-term management, we all know that febuxostat had bad cardiac effect, and it is conditionally recommended to avoid in patients with cardiovascular disease or events. Allopurinol is preferred as first line, but take care of side effects of multiple reaction syndromes. Use lowest effective dose, titrate dose according to response with close monitoring, and uricosuric drugs contraindicated at lower GFR. Also, you have to consider other drugs and the medical conditions that may coexist and affect uric acid level. And finally, hyperuricemia in CKD increases all-cause mortality. And thank you.
Thank you very much, Dr. Mohammed, for this very nice presentation. It's an excellent presentation, well prepared, included a very interesting lesson in how to appraise the evidence, and we shouldn't take any article as dogma, even if it is published in New England Journal of Medicine. We should be careful because randomized control trial is the best study to problem. As you mentioned, we shouldn't generalize the results of any randomized controlled trial, and we should look at the demographic criteria of the patients included in randomized controlled trial. I have few points to leave a room for the discussions, and I'd like to hear from Dr. Tarek El-Tantawy and my colleagues and professors about the issue of uric acid. Is there an optimum uric acid? I think this is the problem, because we don't know, is hyperuricemia a cause or association? And at the best, it's association. But from observational studies and experimental studies, hyperuricemia is bad, associated with inflammations and activation of inflammasome and increasing CKD progression and cardiovascular problems. So we don't like hyperuricemia. Either it is association or it is a bystander. But there is a very nice Japanese study to answer the question, which is the optimum level of serum uric acid. And they found the best serum uric acid in females is between 2 to 4 milligram per deciliter. And in males, it is less than 5 milligram per deciliter. So in female, it is 2 to 4. We don't like severe hypourecemia, as you mentioned, to be associated with many problems, including stones. And we don't, for female, there is estrogen, which is uricosuric. This is why the best level in female is 2 to 4, and in males to be less than 5. If we go beyond this value, you can find cardiovascular diseases, hypertension, CKD, and the CKD progression. But as you mentioned clearly, there is no strong evidence from interventional studies to recommend hyperuricemic therapy. But the best is to follow diet and lifestyle modification. And I like the style of Dr. Riyad Saeed, because even in symposium, in this webinar, he is walking. So exercise and diet modification is essential for all patients, and we don't need evidence in this issue. I would like to comment on the CARES trial. And you mentioned that the rheumatology guidelines mentioned that febuxostat is associated with mortality. And I considered this trial in 2 years ago in the ESKD Congress. Allopurinol is more safe than febuxostat, but I would like to update you, because in this month, August 2020, Mayo Clinic Proceeding published a very nice meta-analysis, 15 randomized controlled trials, including 16,000 patients. No difference in mortality between febuxostat and the allopurinol, and no significant cardiovascular disease. Although the meta-analysis, there is some weakness in the evidence, but I think there is no difference in mortality, and this is the most recent evidence. Yes, losartan is uricosuric, but I don't like this drug because it is the weakest ARBs for treating hypertension. And it is one of the ARBs that may be associated with angioneuritic edema, like ACE inhibitors. I would like to stop here because we have many professors and colleagues to comment, and I'd like to hear from the boss of the session, Dr. Tarek El-Tantawy. Please unmute yourself, Dr. Tarek.
Okay,
yes.
Okay. Many thanks, Dr. Gawad, for your excellent presentation. And it's panoramic and cover a lot of issues. But please, I am with Dr. Hussein as regard usage of uric acid lowering drugs in a lot of conditions, especially if we have a higher level of serum uric acid. Is number one. Number two, the efficacy of febuxostat versus allopurinol in case of CKD is so clear. Febuxostat is more effective in that situation because, as you said, and as you clarify, we have to use less dosage of allopurinol. Secondly, I met a case before with Steven Johnson syndrome, and actually God saved the life of this patient in our situations. The last curve you clarify about J or U level of uric acid associated mortality. If you see uric acid above 9 or 10 associated cardiovascular with deaths and progression of chronic kidney disease. All we are against to have a patient with hypourecemia, of course, because of the role beneficial effect of uric acid, but also are against to have a higher level of uric acid. As regard the diet, because it's a source of purine, as you know, diet rich in purine. We have a lot of diet. We can guide our patient to avoid its consumptions, to avoid higher level of uric acid. Also, with plenty fluids, take plenty fluids, because our patient do not drink enough, especially in that situation. And also the way of alkalinization of urine. I'm very happy that you clarify the issue of uricosuric drugs, because up till now, we met a lot of prescriptions to use uricosuric drugs in case of advanced or in case of chronic kidney disease. At the end, many thanks for your lecture today, and all we got nice panoramic about the uric acid and the chronic kidney disease. Many thanks.
Thank you very much, Dr. Tarek El-Tantawy, for your very nice comments. We shouldn't use uricosuric drugs for treating CKD patients because of their more and more adverse effect on the kidney. Yes, I agree with this point 100%. This is why we discuss the issue of hypourecemic. And I think in dialysis, it is clear not to use hypourecemic drugs except if there is gout. Because there, as Dr. Mohammed clearly showed, that even in dialysis, hyperuricemia is one of the dialysis paradox. Dr. Dawlat Belal raised her hand. Yes, Dr. Dawlat? Please unmute yourself, Dr. Dawlat.
unmuted كده يولد. سامعني يا دكتور حسين؟
Very nice, Dr. Dawlat.
سامعينك كويس جدا.
Thank you very much, Mohammed, for a very beautiful lecture. اللي عجبني فيها what I liked is that you went deep into the PEAR study because the PEAR study had very disappointing results to the people who conducted it. It was mainly done by mainly 30 centers, mainly by Jocelyn, and they were testing for the early prevention of GFR decrease by using allopurinol. And they were disappointed because they, as you mentioned, there was no difference between the two arms. Lakin at the end, they said that they probably had a very narrow scope of the patients. While you mentioned very brilliantly that excluded young and they excluded the single kidney, yani to limit the scope of the study to hoping for. And there are some people like Professor does not respect these results, and he treats asymptomatic hyperuricemia. I'm not saying, I'm not giving a very serious statement that you're free to treat it, but some people just are not convinced to leave hyperuricemia with all the alleged injuries which you mentioned, you didn't mention, but acting on the ACE system, on the glomerular filtration, on lots of aspects. There are alleged injuries, and I just ignored them because the KDOPI guidelines to 2020 stated that we do not treat asymptomatic hyperuricemia. I personally, I treat them because I believe uric acid can do harm, although it's we cannot pinpoint the exact harm or the single harm, but it's a sort of a consortium of many factors, one of them is uric acid. So what is the point of just disregard and not treating the patient? But this is not a rule anyway. Yes, thank you. And I really congratulate you for a very good lecture. Thank you very much.
Thank you.
Thank you very much, Professor Dawlat, for your comments. Yes, there are some seniors and experts prefer to treat hyperuricemia. But as Dr. Abdel-Gawad elegantly showed, there is no evidence. And I think the old dogma is still valid because since many years, we read in the up-to-date that for asymptomatic hyperuricemia, hypourecemic drugs are to be used if the patient has malignancy and we are afraid of tumor lysis syndrome, or if the patient has very severe values like 13 milligram per deciliter in men and 10.5 or more in women. And lastly, if the patient is uricosuric, so if urinary 24-hour uric acid excretion exceeds 1,100 milligram per day, this is the huge amount of uricosuria, and the patient is hyperuricemic. This means that we should reduce uric acid formation by hypourecemic drugs. These are the classic indications, and I think they are still valid. Sure, gout is away from this because gout is not asymptomatic hyperuricemia. But if we are from the school to use allopurinol, even if there is normal kidney function, as Dr. Abdel mentioned, to start with very small dose. And I like a Nature review last year published how to use allopurinol is to start 50 milligram, as Dr. Abdel mentioned, and then to elevate the dose, titrate the dose every 2 weeks, even if the kidney function is good, until we reach the maximum dose adjusted by the GFR. And by this strategy, we have a time to monitor side effects. Dr. Tarek El-Tantawy mentioned that he has a case of Stephen Johnson. I witnessed 2 cases of toxic epidermal necrolysis. It's a fatal syndrome. We have 2 patients, one died and one saved, but this is regarding the issue. I'm leaving the mic to Dr. Riyad Saeed because he raised the hand. Dr. Riyad, please unmute yourself.
مساء الخير. Good talk, Dr. Zamilna. It was a good, thorough lecture. I have 2 or 3 points. Now, what's really your cutoff point for asymptomatic hyperuricemia? What's the cutoff point that your hands are get itchy and you have to treat? That's the first one. Secondly, I agree 100%. Nowadays, febuxostat is more reliable drug for the treatment than allopurinol. Thirdly, be sure, please, we have patients who are transplanted and they are really on some drugs, myclophenolate or azathioprine. When we give them such medication, it will be really disaster. Thank you.
Thank you very much, Professor Riyad, for these very valuable points. Because as I mentioned, if we go to the up-to-date statements, uric acid above 10 in women or 10.5 and 13 in men. I think we nowadays reduce this cutoff point. So we don't like these very high values. But as Dr. Abdel, the evidence is not strong. So we should be very cautious and educate the patient, as Dr. Mohammed Saeed wrote in the chat. We should educate the patient to monitor side effects and know the evidence. Sometimes diet and exercise are very valuable. And as Dr. Tarek El-Tantawy mentioned, hydration, because one of the Mesoamerican syndrome, because Professor Richard Johnson, who is famous by Mesoamerican syndrome, is very believing in uric acid and reducing uric acid. So he considers uric acid is a big enemy for the kidney. And if we are believing in the same school, we should start slow and go, we'll start low and go slow. So the cutoff point is variable. And I would like to hear from Dr. Riyad.
I think around 10. I think, around 10, I will treat.
Okay, I agree with you because we don't wait until 13 milligram in men like up to date. And we consider 10 is very high level, especially if the patient in the early stages of ESKD, because this is a good action to be done with drug use. Febuxostat in many studies was shown to be more effective for the management of hyperuricemia and the reducing and the retarding progression of chronic kidney disease. But again, as Dr. Abdel today, we learn from him to appraise all these studies, because I know there is a very to read the sample size is very small. So we shouldn't be trapped by companies and because of the expense. I don't have an evidence of efficacy. So by this way, I should take the low price drug. Regarding transplantation, we learned it a lot, Professor Riyad, from the interaction. Allopurinol is an oxidase inhibitor, and azathioprine or imuran is metabolized by the oxidase. If I block the oxidase pathway, this means that I elevate the level of imuran that may lead to toxicity. In the past, we use this cocktail. We write the immune suppression drug, steroid, cyclosporin, azathioprine, and then with allopurinol, we use half tablet of imuran, 25 milligram, with the dose of allopurinol. And we should taught all the attendees, and we should write the patient is on this drug. Nowadays, we have mycophenolic acid related drugs, either MMF or myfortic. So there is no room nowadays in transplantation to use rheumatology. If we decide to use this combination because of the price and the patient is not covered by insurance, we should measure and stick to the science. We should know the TBMT, thioberine methyltransferase enzymatic activity, before deciding to continue, because imuran is metabolized by two pathways. If I block the oxidase by allopurinol and the patient is unlucky because TBMT is very low, then this combination will lead to catastrophe and disaster, as Professor Riyad mentioned. The same interaction are with febuxostat. So both febuxostat and allopurinol interact badly with azathioprine or imuran. And I prefer in managing gout in transplant patient is to use steroid and not other drugs. And I like the style of the colchicine toxicity, because colchicine may kill the patient. If the patient is treated with antifungal, for example, and it was shown in the slide, but Dr. Abdel doesn't comment on this issue. If the patient is treated with antifungal drugs, we should be careful, because the use of colchicine may be fatal in this case scenario. Do you like to comment, Dr. Riyad?
Well, I agree 100% really with this. I think less and less use of imuran, but we have ladies who are really planning to get pregnant, or so, like some of them, they are really subject to this. But I agree with you, with all your comment, we have to be careful with the use of these drugs. One final point really I'd like to say, that diet is significant, but again, we have to know that 15% of our uric acid is really coming from the diet. Most of our uric acid is coming endogenously. So really, no matter how much we can try with the diet, still our patient will not comply, and we may have to revert for medication.
Thank you very much, Dr. Riyad. Really fantastic comments. Dr. Faissal Shaheen.
Thank you very much, Prof. Hussein. Mohammed, excellent talk and very well organized and very informative. I like the way you presented, actually. Many of the comments which it was in my mind actually being addressed by some other colleague, especially the interactions between allopurinol and azathioprine, which we were using as a long time back, and we know that we have to sacrifice one of them or sacrifice the kidney, especially post-transplant with leukemia, and the disaster which could happen by using aza plus allopurinol. So this is we have to put in mind. But my questions to Mohammed, we are facing a lot of patients coming with high creatinine, hyperuricemia, asymptomatic hyperuricemia, and yet when we treat the uric acid, bring it down, the creatinine also come down. So how can you explain this, and how can we just say that we don't treat asymptomatic hyperuricemia, and this can affect badly the kidney or the creatinine? Thank you.
Thank you, Dr.
I saw some patients with high uric acid asymptomatic hyperuricemia, and yes, as you said, Prof, that with the management of hyperuricemia, the creatinine goes down. But actually, these patients, as I saw, had many other uncontrolled factors, uncontrolled hypertension. They are not on well diet, many other factors. So I think that correction of other factors besides the correction of hyperuricemia may be the main factor for the improvement of creatinine and the kidney function. But if a patient, I see some patients, but not many patients, I controlled many factors or all the factors, and he's still progressing, but slowly, and I treat asymptomatic hyperuricemia. Some of them respond to the management of hyperuricemia and some or not. And this again may show the debate of the evidence about the treatment of asymptomatic hyperuricemia or not. And this will go to the individualization, because actually we may not know what is happening at the tissue level of hyperuricemia in our patients, except by biopsy or whatever. So that's what make some patients may respond to the management of hyperuricemia and some may not.
Okay.
If you allow me, Dr. Gawad, because me and Dr. Tarek El-Tantawy are convinced by treating hyperuricemia. Do you agree with me, Dr. Tarek?
Yes.
Although the evidence is very low,
Yes.
but we like to treat hyperuricemia because we are convinced by all pathophysiology linked, as Dr. Faissal just mentioned, with hyperuricemia. So if we start in a wise way by very small dose of allopurinol, it is very cheap drug, and to monitor uric acid, even if the evidence is low, and so long as we are observing the patient well and educate the patient, I think I am from the school that's convinced by the hazardous role of hyperuricemia. Although I attended a debatable session moderated by Professor Barsoum a couple of years ago with Dr. Zaghloul, and we had at that time two elegant speakers, one defending treatment of hyperuricemia by hypourecemic drugs, and one against. And at the end of the debate, the evidence was, as you mentioned, there is no evidence. And the Dr. Rashad Barsoum announced it at the end, and the vote was not to treat hyperuricemic state by hypourecemic drugs. But I am from the school, we don't like severe hyperuricemia. So if, let us say, if uric acid is above 10 or above 9 milligrams per deciliter, it's better to hydrate the patient and start small dose of allopurinol. Do you agree, Dr. Tarek, about this point?
Of course, Dr. Hussein, and as regards diet, we have diet with amount of uric acid different, because, for example, diet containing mild, moderate, and severe. For example, mackerel and organ meat and some avocado and some vegetables have a high content of uric acid. On the other side, some proteins like meat, poultry, and even fish contain moderate amount. We cannot make our patient not to eat this because of hyperuricemia. And as you see,
I agree with you 100%. And this was my comment during the debate led by Professor Barsoum. I said to him, I should treat, but I should treat with lifestyle and diet first, and then to think of hypourecemic drug. Should I use or not, according to my preference and according to the wisdom of starting low and go slow, educate the patient and observe the side effects.
And the follow level of uric acid, yes. Yes,
and I like the study of Japan that the ideal uric acid is 5 milligrams per deciliter. It's the best. But if we allow 5 to 8 or 5 to 9, and then after that we start think of using hyperuricemia, and the diet and the exercise should be from the start, even with normal uric acid. We should follow lifestyle because lifestyle modification is of paramount importance. There is a question in the chat, Dr. Mohammed. If you have anemia, is anemia a modification factor for the management of hyperuricemia?
The patient is with a gout flare, or patient has a gout?
Asymptomatic hyperuricemia. If the patient is gout,
no, I will not treat him. I will correct. In my practice, I don't treat asymptomatic hyperuricemia until I correct all other reversible causes. I correct anemia, blood pressure, etc. If the patient is still progressing and still hyperuricemic, even if asymptomatic but with high levels more than 8.5, I start to treat asymptomatic hyperuricemia. And if there is a stationary course of GFR or GFR becomes better, I continue urate-lowering therapy. If not, and there is progression, I may stop the urate-lowering therapy.
Dr. Saeed Khamis?
Yes, yes, sir. Thank you, Dr. Hussein. Thank you, Dr. Gawad, for this elegant presentation as usual. I have 2 comments and 1 question, if you allow me, Professor Hussein.
You are allowed. Go ahead.
Okay, thank you. Number 1, if you remember, Professor Hussein and Dr. Gawad, regarding this article published in the NEDT maybe 5 years ago, regarding it was a review article regarding uric acid is a friend or foe. And after some years, Professor Barsoum gave the same title of the same lecture regarding uric acid friend or foe. It was very elegant lecture, as you mentioned also.
It is a masterpiece, Dr. Saeed. I'm sorry for the interruption, but it is a masterpiece of lectures. It is very fantastic. And I upload it to the site of ESNT Virtual Academy, and I recommend all my colleagues and the professor to look at Professor Barsoum because we learned a lot from this presentation.
That's what I would like to say, actually, yes, as you said. So, number 2, regarding the urate lowering medications. Actually, we are, many among us as a physicians or nephrologists, we prescribe overzealously or over-enthusiastic over-prescription of this allopurinol. Allopurinol is not a chocolate. Allopurinol, as you said, and Dr. Gawad said, has many side effects, and Dr. Tarek said, and you said also has disasters sometimes, I mean. So we should be careful when we prescribe allopurinol, and we should monitor the side effect closely for our patient. That's number 2. My question regarding the uric acid, if you have a patient with normal uric acid level, and he has CKD, say creatinine 2 or 3 or whatever, and I saw many doctors prescribing allopurinol for these patients based on that it has a nephroprotective effect, based on that it has an antioxidant, free radical scavenger, and so and so. Despite this, allopurinol itself can induce chronic interstitial nephritis and many bad effects on the kidney. What is your opinion, Dr. Gawad and Dr. Hussein? Thank you so much.
These are theoretical evidence. I can't use it in our patients. The effect of antioxidant effect or whatever the beneficial effect of allopurinol is only experimental. There is no, even the PEAR trial and CKD fixed trial that I showed now had patients with normal serum uric acid level included and show no benefit finally of the use of this medication. So I don't recommend to use it in normal uric acid CKD patients.
Yeah, thank you.
The same Dr. Saeed.
Yeah.
Even if it is shown in experimental studies to have antioxidant effect, but it is it shouldn't be translated to human until we have studies documenting the evidence. The evidence in the presence of hyperuricemia is debatable. So how to agree to use it in the presence of normal uric acid? I don't agree at all, even if there is some comment.
Me too, yeah.
Yes.
Yeah. One last comment, Dr. Hussein, regarding the hypourecemia. Hypourecemia, if you accidentally find it in a lab results with a patient with low BUN, low sodium, and other parameters, we should think of SIAD at that moment. Or if you see a patient with hypourecemia and chronic unexplained elevated liver enzymes, we should think of Wilson disease. Just I would like to say like this. Thank you.
Thank you very much, Dr. Saeed, for your comments. And
I would like to add, please, Dr. Hussein, about metabolic syndrome and the insulin resistance, management of hyperuricemia, management this issue, and the patient, as regard the insulin sensitivity, will be improved with the usage of uricose lowering drugs.
And if you remember my comments during your presentation at Ain Shams University, the issue of very low GFR. If we have a low clearance clinic, the estimated GFR less than 15 milliliter per minute, it's better to avoid febuxostat. And if we should use allopurinol. Why? Because of the dogma. I always respect the observation. 40 patients had myositis, and some of them had rhabdomyolysis if febuxostat is used in very low GFR. So in this category of patients should be very cautious for using a hypourecemic drug, especially febuxostat. Is there any comments, or to stop here, Dr. Tarek?
Okay, stop.
Stop here. Okay. At the end of this session, I'd like to thank and appreciate the efforts done by Dr. Abdel-Gawad. It's a very nice presentation, full of many messages and lessons, how to prepare a good presentation, how to appraise a literature, even a paper or two papers in New England Journal of Medicine don't drive my mind toward the right or left. I should think, and I should utilize my approach to individualize our treatment strategy as we agreed by Dr. Tarek, Dr. Riyad, Dr. Faissal, Dr. Dawlat, and Dr. Saeed, and myself. It is personalized medicine. Whatever the strategy we follow to treat or not to treat hyperuricemia in asymptomatic hyperuricemia by hypourecemic drugs, we should be careful, monitoring GFR. There is no colchicine at all in CKD patients, except if I modify. In dialysis patients, even 0.3 milligram twice weekly is enough from colchicine. Otherwise, colchicine may kill the patient. Regarding the Dr. Dawlat raised her hand before conclusion. I'm going to give her the mic. Dr. Dawlat, please.
Unmute.
Unmute.
Yes. Dr. Dawlat.
You mute yourself. هي عملت mute لنفسها تاني.
Unmute yourself, Dr. Dawlat.
Now you hear me?
Yes.
Yes. Right.
Thank you, Dr. Tarek, very much for reminding us of the metabolic syndrome. In the metabolic syndrome, you have hypertension, hyperglycemia, hyperlipidemia, obesity, coronary heart disease, and hyperuricemia. Yes. We very enthusiastically treat everything, and you are asking us to disregard the uric acid. So I think it's an asymptomatic hyperuricemia in this situation. So I think it is very logical to treat the hyperuricemia in metabolic syndrome.
Yes. I would like to hear from you, Dr. Dawlat, because I remember your presentation. We have one of excellent presentation about uric acid and kidney from Professor Dawlat Belal, and it is recorded and it is uploaded already. And the last point that I would like to hear from Prof Dawlat and to hear from Dr. Tarek and Dr. Abdel-Gawad, the issue of gouty nephropathy. Do you agree about this term, or should be condemned and not mentioned anymore? Gouty nephropathy.
You're addressing
the issue of uric acid associated nephropathy. Do you agree about this term, or this debatable term?
I think the title itself is rather not very accurate. It's either an interstitial nephritis or renal stones, but nephropathy in general, it's not very popular to use this term.
It is a debatable term.
Dr. Riyad Saeed raised his hand.
Dr. Riyad?
I think yes, I think the only time you can call it uric acid nephropathy if you can document uric acid crystals in a tissue biopsy, and that's not being done because we don't handle the kidney biopsy in the proper way. If you suspect that, you have to keep it in absolute alcohol in order not to dissolve the crystals. In formalin, we dissolve the crystal, you are not going to see it. If you are highly suspecting the cause as urate nephropathy, as you said, chronic urate nephropathy, you have to fix the specimen in absolute alcohol.
And even if we find uric acid,
I know.
within the tissue,
but that's the only way. I agree with that's the only way you can call it's a possibility of urate nephropathy. Yes.
Thank you very much, Dr. Riyad, for this clarification. Dr. Dawlat, would you like to add anything before closing?
No, maybe in the acute uric acid nephropathy, and I don't call it in tumor lysis syndrome. This is a different situation. But to say
and
chronic
tumor lysis
nephropathy,
yes.
No.
Yes, okay. And in tumor lysis syndrome, this is the place of uricase, rasparase, or component human uricase, because we don't have uricase in human. And this is why, and the rasparase is fantastic because it can derive uric acid even to very low figure or even zero. So the
and even the research may require hemodialysis.
Yes, okay, but it doesn't need modification in CKD patients. I think so. At the end of this session, I'd like to appreciate the efforts of Dr. Abdel-Gawad. Very nice, excellent presentation.
Thank you.
And very satisfactory. And the PowerPoint is uploaded and the video will be uploaded tomorrow morning. Also, I'd like to appreciate the presence of Dr. Tarek El-Tantawy as a moderator and all my professors and colleagues who shared in this discussion. And as a symbol of appreciation, where is this? This is the Dr. Abdel-Gawad, the speaker. We appreciate your presence, and this is our style nowadays is to document by certificate. It's just a symbol of saying thank you from the CME and from the society.
Thank you.
And this distinguished contribution in the fantastic presentation about uric acid and the CKD, and as well the moderation of the joint moderator, Dr. Tarek El-Tantawy. I'd like to thank all my professors from Arab world, Professor Riyad Saeed, Professor Faissal Shaheen, from Egypt, Professor Dawlat Belal, Professor Saeed Khamis. Thank all my colleagues who attended this meeting, hoping you all the best, inshallah. Thank you and goodbye.